Hi, everyone. My name is Mike Levin. I'm a cardiology fellow at the University of Pennsylvania. Welcome to CVI Heartbites. CVI Heartbites is a free, non-accredited educational program produced by the Cardiovascular Institute of Philadelphia, featuring succinct presentations delivered by leading experts on timely topics in cardiovascular medicine. This CVI Heartbite segment focuses on cardiovascular disease in the age of COVID. Please note this presentation was recorded on April 20th, 2020, and the information was up to date as of that time. At the end of this presentation, you'll have the opportunity to see some additional resources and contact us with further questions. So the main objectives of this presentation today will be to review cardiovascular disease as a risk factor for COVID-19 and poor outcomes, and then review some of the cardiovascular manifestations of COVID. This isn't a comprehensive presentation, and many of these topics will be discussed in more detail in other Heartbite segments. So first, we'll focus on the idea of cardiovascular disease as a risk factor for COVID-19 and poor outcomes. This idea was raised quite early in the worldwide pandemic. Shown here is a table from an article published in The Lancet based on the experience of a group in Wuhan, China, looking at 191 patients admitted to the hospital with COVID-19 in up to January 2020. And they very early on identified cardiovascular disease and related traits as risk factors for in-hospital death. So this group identified coronary heart disease, diabetes, and hypertension. Similar findings have been described in a number of other series since that time. Recently, a group from New York University published a preprint of their experience with more than 4,000 patients with COVID-19 that presented for care in New York City in the month of March. Again, they looked at a number of underlying demographic risk factors and comorbidities, and here's a subset of cardiovascular related traits. In terms of risk of hospitalization, this group identified diabetes, heart failure, and obesity as risk factors and found a potentially protective effect of hyperlipidemia. And when thinking about risk of critical illness, including need for intensive care, intubation, mechanical ventilation, and death, the authors only found actually obesity to be a predictive factor. The mechanism by which cardiovascular disease may increase risk of COVID-19 and poor outcomes has been hypothesized to be related to the ACE2 receptor. So this is the receptor that the virus uses to enter cells and is thought to cause direct viral toxicity and predispose patients to an aggressive host immune response. The ACE2 receptor is expressed in a number of tissues throughout the body, including the heart and other metabolically active tissues. And both preclinical work with animal models and some human studies have identified cardiovascular diseases like heart failure, cardiomyopathy, hypertension, and cardiovascular medications as affecting ACE2 levels in these different tissues. Whether this variation in ACE2 expression actually leads to changes in outcomes remains to be seen, but this at least has been the proposed mechanism by which COVID interacts with underlying cardiovascular disease. I think it's important to recognize, though, that when we see these associations between cardiovascular disease and risk of COVID, we should also consider some other explanations. So importantly, we know that age is a strong risk factor, both for cardiovascular disease and poor outcomes with COVID. And it may be that we pick up cardiovascular disease just as a bystander and that there's no direct biologic effect. And we should also consider the idea that the association between cardiovascular disease and COVID and poor outcomes may be biased. So for example, patients with cardiovascular disease tend to be sicker in general, and when they present for care, may be more likely to be admitted to the hospital regardless of their COVID disease. Next, we'll review some of the cardiovascular manifestations of COVID. This isn't a comprehensive list, but some of the important cardiovascular manifestations include acute cardiac injury, acute coronary syndrome, thromboembolic disease, myocarditis, and cardiomyopathy. And as mentioned before, many of these will be discussed in other Heartbite segments. So starting with acute cardiac injury, it's a very broad manifestation, generally defined only by cardiac biomarkers being elevated. Some groups also consider EKG changes and echo abnormalities, but really the defining feature is elevated cardiac biomarkers. There's a number of proposed mechanisms for acute cardiac injury, but I think it's helpful to break down into two groups, kind of direct injury mediated by ACE2 mediated viral toxicity, and then indirect mechanisms that are related to the combination of acute illness with other underlying cardiovascular risk factors, either coronary disease, hypertension, heart failure. Here's, I think, a nice figure that we won't review in detail from an article recently published in one of the JACC journals. But I think it's important to highlight the complex interplay between kind of the manifestations of COVID and mechanisms by which they lead to myocardial injury. And I'd refer you to this article to learn more. We know that acute cardiac injury is quite common among patients, at least those hospitalized with COVID, with up to a third of patients developing this condition. It's probably less common among the general population, but certainly among ICU patients, there have been reports of even higher incidence of acute cardiac injury. At this point, we don't know if there's any specific treatment changes that we need to make based on the presence of cardiac injury, but there's certainly some important prognostic implications. So studies have described increased use of mechanical ventilation in these patients and a consistent signal for increased mortality in patients that develop acute cardiac injury. And I think important to highlight the idea that patients with underlying coronary disease and cardiac injury seem to do particularly poorly in comparison to patients with no cardiovascular disease and negative troponins. The next clinical manifestation to consider is acute coronary syndrome. We don't have a lot of great data thus far with COVID, but I think it's helpful to look back to the relationship between acute coronary syndrome and other respiratory illnesses. And so there was a nice study published in the New England Journal a few years ago that looked at rates of myocardial infarction following hospitalization for influenza and other respiratory viral infections. And they found that in the few days to week following those respiratory infections, the risk of myocardial infarction was quite high. The authors proposed a number of potential mechanisms here, including inflammation, vasoconstriction, and increased metabolic demand in combination with hypoxia, leading to supply-demand mismatch. Whether these mechanisms are at play in COVID, I think remains to be seen, but will be interesting to look for as we gather new data. Another cardiovascular manifestation that's been reported quite commonly is thromboembolic disease. So again, nearly a third of patients hospitalized in some reports have experienced coagulopathy and thrombocytopenia. And there have been a number of case reports of patients developing thrombosis despite the use of prophylaxis. This has led a number of groups to start using therapeutic anticoagulation, and in some cases, even systemic thrombolytics to try and treat these patients. As of right now, the American Society of Hematology recommends not pursuing those aggressive measures outside of another indication for anticoagulation, so a known venous thromboembolism or atrial fibrillation. But will be interesting to see whether targeting thromboembolism therapeutically may improve outcomes in some of these patients. Like the other cardiovascular diseases, we know that thromboembolic disease confers a poor prognosis on these patients. So elevated D-dimer, coagulopathy, and disseminated intravascular coagulation have all been associated with poor outcomes among patients with COVID. Another cardiac manifestation that has been proposed is myocarditis. So we discussed earlier that acute cardiac injury is quite common, and many groups have reported patients that present with chest pain, may have ST elevations on their electrocardiograms, and when they go for coronary angiography, end up not having any epicardial coronary artery disease. And so this has raised the question of whether these patients may be experiencing actually myocarditis. We don't have a great handle yet on whether myocarditis is actually occurring, and that's due to limited biopsies that have been taken, limited cardiac MRIs, but there have been a few reports of autopsy series at this point. So a group in New Orleans and the University of Washington have described their experiences. They've identified some level of myocyte necrosis in patients and some inflammatory infiltrates, but have not actually found histopathologic evidence consistent with acute myocarditis. I think as people become more comfortable with diagnosing patients, maybe pursuing more biopsies and cardiac MRIs, we'll get a better sense of how common myocarditis truly is. And I think the final manifestation that we'll discuss today is cardiomyopathy. Some series have again reported up to 1/3 of hospitalized patients developing systolic dysfunction. And again, a number of mechanisms have been proposed, including stress cardiomyopathy in the setting of acute illness, microvascular dysfunction in the setting of thromboembolic disease, direct viral toxicity as a consequence of myocarditis, and then as a consequence of acute coronary syndrome. Thus far, we don't know if there's any kind of changes in treatment that we would make based on the identification of cardiomyopathy, but patients that develop cardiac dysfunction seem to be at elevated risk of mortality and poor outcomes. So overall, I hope what you've taken away from this presentation is that underlying cardiovascular diseases may be associated with COVID-19 and worse outcomes. There have been some proposed mechanisms by which this may occur, but underlying cardiovascular disease may just be a bystander and a marker of sick patients in general. And then there have been a number of cardiovascular manifestations of COVID-19 that have been described and consistently seem to be associated with risk of poor outcomes. And thus far, there aren't any specific treatments, but will be interesting to see over the coming weeks and months whether any are developed. Here's several additional resources on COVID and the heart. If you have additional questions for me, feel free to email CVI's Executive Director, Mark Hartnett, and he'll forward the questions to me. Feel free to share this link with anybody who might be interested in the information, and let us know if there's other topics of interest for you. Thanks for watching this CVI Heartbites segment. For more information on other CVI Heartbites segments, as well as other CVI educational programs, please visit us at cviphiladelphia.org or follow us on Twitter at CVI Phila.